going to be a heavy focus accordingly. Okay. All right. So I guess we'll get started. One of your colleagues sent me something with Spectrum, and I'm having trouble with that, but I'm going to try to see if I can revert to that, but I'm still on hotspot. I'm also at a friend's home who needs a little assistance, so you may hear noises or sounds accordingly. Okay, but just to give you a heads up. All right, so now we're going to get going. So we'll do the same thing. You'll kick in if you have a question by either, generating a comment verbally or texting to me accordingly. All right. Okay, so here we go. Upper respiratory tract disorders. Now, upper respiratory tract is the most common reason for seeking health care. They can go the gamut, just being minor to life-threatening, like this coronavirus. They can be treated in a community setting, and that, in terms of what defines a community setting, would be doctor offices, urgent care clinics, long-term care facilities, or self-care at home. Early detection of signs and symptoms can avoid unnecessary complications. Patient teaching is important, and you have to have special consideration for older people because they're at a more risk group, at a more risk group with regards to what their other chronic illnesses that go along with it can also be a stressor to their system. So in terms of looking at upper respiratory tract infections, you have rhinitis, rhinosinusitis, could be acute or chronic, tonsillitis. You could have a peritonsillar abscess or laryngitis. And as you well know, that whenever you see itis, that means inflammation. Okay, so with that suffix, you know that there's some type of inflammation going on. Whether or not it's infectious or not has to be defined outside of the term. So when you're looking at rhinitis, basically you're looking at, once again, the inflammation, and you're seeing an enlargement of the mucosal membrane. And subsequent to that, you could see discharge, mucus discharge. And I know I've said this a number of times before, but in terms of mucus discharge, you're looking at going from clear to multiple colors. And once you start to see colors, specifically yellow and green, you're really looking at an infection. If it's clear or even white in nature, generally speaking, it's not an infection. It's when you start to see colors like yellow and green that you'll see you could suspect subsequently an infection. But the only way to identify the organism of that infection, or any infection for that matter, is to culture it. And the culture and sensitivity is, in a sense, looking at the organism and seeing what the organism is sensitive to, so that you can be more exact in terms of what antibiotic needs to be ordered. Rhinosinusitis, you have, it becomes a little bit more complicated because it's not just that inflammation. You're also looking at a more sense in terms of what might be occluding passageway. Now, in terms pharyngitis, you're looking at once again a swelling up of the pharyngeal region, and you can see it most pronounced on the on the right side in terms of the redness accordingly, and in terms of occlusion, and also on the left side as well. But you can definitely see the redness here. So, which of the following statement true or false? Acute pharyngitis of a bacterial nature is most commonly caused by group A beta hemolytic streptococcus, streptococci, and the answer is true. And that's why, when you're looking at working with children in particular, at least in the past, they used to always, swab you to make sure that you weren't a carrier bringing in strep for those babies that are at risk in the neonatal ICU, for an example, or in a special care, special care nursery accordingly. Okay. So in terms of upper respiratory tract potential complications, you're looking at airway obstruction, which makes sense because if you have swelling and part of the component of the passageway is that upper airway, and you've gotten swollen areas, you're not going to be able to inhale and exhale appropriately. You could have hemorrhage because now that tissue is irritated, and subsequently it could cause bleeding. The idea of sepsis. Sepsis is when you have a system-wide body attack on a microbe, generally speaking, bacterial microbe, and subsequently, there's always a focus of origin. And the upper respiratory tract could be such, a focus. Meningitis or brain abscess. If you go back and look at the picture of the pharynx, the sinuses and the sinuses accordingly, you'll see how close it is to the base of the brain. And in fact, when you learn about neuro, you're going to see that one of the operative approaches with regards to dealing with the pituitary is they're going to what they call do a hypophosphosectomy, which is they'll put like a tube in that region and then go back. As you see, can you see where I'm pointing the arrow? They'll go back to the pituitary through that route. And so that if you have a bad enough infection, it could erode the bone and be problematic in terms of an infection there. Looking at meningitis or even brain abscess, and the nuchal rigidity would come from the meningitis. Once you irritate or inflame those layers that surround the brain, okay, they become stretched out. And those layers that surround the brain also surround the spinal cord as well. So once they become inflamed, they're not as flexible, so you can't bend your neck as easily as you once could. Medicamentosa, you're looking at once again in relationship to those membranes and having issue in terms of infection once again in that region that could compromise further that connection. In terms of otitis media, that's obviously an ear infection. Trismus also, you're looking at dysphagia, not being able to talk as well because now that tissue that you use in terms of speech is now compromised. Aphonia, once again, leading to that as well. And cellulitis is basically inflammation of tissue. So when you're looking at the nursing process and you're looking at upper respiratory, when you're looking at your upper respiratory, when you're looking at your upper respiratory infections in the nursing process, you have to start off with assessment. And that assessment deals first and foremost with health history. So you have to ask, well, what exactly, where have you been? What's your pre-existing health concerns, etc. You're going to look to the signs and symptoms, the idea of headache because of the pressure in the sinuses, cough, hoarseness, fever, a sense of stuffiness and fatigue, as well as generalized discomfort because of the compromise related to your disease entity as you see it. Allergies, you need to know, is it the allergy season? Is this what's causing it? And then ultimately, in regards to inspection of the nose, neck, throat, and palpation of your lymph nodes to see exactly what's happening in terms of that inflammatory process. So that should a nurse palpate when assessing for what should the nurse palpate when assessing for an upper respiratory tract infection? And the answer would be as we just mentioned, your lymph nodes, because they go along the side of the trachea and frontal and maxillary sinuses, and this would show if they start to become inflamed and they'll become enlarged, and you'll be able to palpate them, and that would also be a sign of an upper respiratory infection. In regards to the nursing process, in terms of looking at different nursing diagnoses that would go along with upper respiratory infections, you would look at ineffective airway clearance because of that swelling, acute pain. You won't be able to, speak well because of the rawness of the tissue. In terms of fluid volume deficit, anytime something is inflamed, it's going to steal fluid from the circulatory system, and hydration becomes important. And then obviously in terms of knowledge deficit for the patient in regards to preventing and treatment, if there needs to be a surgical procedure and post-operative care, all of that lends itself to patient teaching. Now, your planning that goes concurrently with this diagnosis, obviously with the ineffective airway, you want to have airway management, decrease the chance of aspiration. You want to have pain management for the acute pain. You want to have effective, communication strategy, because the person may not be able to speak well. That's where you get communication boards. You want to, obviously, like I mentioned before, increase hydration, and the idea of patient teaching needs to follow as well. So your interventions would be if the patient, not even if the patient's in the hospital, but if the patient, to remind them to keep their head elevated. If they're in the hospital, keep their head elevated, but at home to keep their head elevated. And the idea of an ice collar to reduce any inflammation or bleeding, and hot packs over the region was where there may be congestion. You want to give analgesia for pain, gargle for sore throat, and as I mentioned before, for communication purposes, you may need to use an alternate means of communication. You want to give fluids. You want to administer fluids to make sure that they're hydrated. So generally speaking, you're looking at 2 to 3 liters a day. Normally, we take in 1,500, the average adult. So this is a little bit more or a lot more than what you would normally take in this volume. You want a soft diet because you don't want anything else further scratching your throat. And obviously rest in order to decrease your metabolic needs so that those calories can be used as a form of treatment modality. And then, you want to, in terms of evaluation, you want to make sure that the person's expressing relief of pain, they're able to communicate, they're showing, that their tissues are, adequately hydrated, that you're not, you're seeing that there's good skin turgor accordingly, and you want to make sure that there's no complications. Insofar as patient education goes, you want to look to prevention of upper airway infections, and in terms of upper airway infections, somebody just texted me here from class. Hold on. Okay. All right. They got on. All right. Sorry. Okay. So in regards to prevention of upper airway, a lot has to do with, once again, we're using this word quarantine, but you want to limit the transmission of the organism. And in that regard, you're going to separate, if you're at home, if you have paper cups or cups that you can throw out, but you're going to separate and keep anything that's from the oral region away from other members that habitate the, that homestead or whatever. You obviously want to do frequent hand washing, 20 to 30 seconds. And hand washing isn't just putting soap on. It's rubbing your hands together, folding your one hand over with your nail bed, and then folding the other hand over with your nail bed in your palm. And then, once again, rubbing the two hands together, and then rinsing them under the water. And really, soap is important, but really that friction is what does it in terms of really getting rid of what may be topically on your hands. You want to contact your healthcare provider if you have a fever. That's generally speaking when you contact that individual, or if in 72 hours you're not seeing resolution in general, not just with COVID-19, but in general with your symptoms as they present. And the old adage is that, people take antibiotics and then after 2 or 3 days they feel better, so they say, oh, I don't need them anymore. Well, you need to complete the whole dose, or else you're going to set yourself up for super infection. So what if they tell you to take antibiotics for 7 to 10 days, you take them for the 7 or the 10 days that they've ordered them for you. And then in terms of the flu vaccine, so healthcare providers, as well as those patients generally at risk, need to get the flu vaccine. And healthcare providers, because in order so that they don't transmit the disease to somebody else. In terms of obstruction of the upper airway, one of the main, causes that you're going to see is, sleep apnea. And with sleep apnea, some of the signs and symptoms, and one big sign and symptom is loud snoring. So loud snoring generally tells you that the person is suffering from sleep apnea. Obviously, if somebody is observed to have periods of apnea, and when you're in the hospital and somebody's on a bedside monitor, that's where you're looking at this respiratory curve, all right, and which is really a breath curve. And it'll actually show you, and you'll see it, that the patient is, taking breaths, and then all of a sudden you'll see a flat line for 10 seconds, however long it is, accordingly. And then there's something that every bedside monitor that's been made in the last 10 years is something known as oxy-CRG. And it really looks at oxygenation, cardiac, as well as respiratory graphs. So they'll graph everything together to see where oxygenation goes. And I'm sorry about that phone. That, like I said, I'm at someone's house. So in terms of looking at the bedside monitor, you're looking at, once again, oxy-CRG. So oxygenation, which is your pulse oximetry, cardiac, you're looking at your EKG, and respiratory, you're looking at the respiratory curve as well, in regards to that graph. So loud snoring and observed apnea outside of the hospital is an example. Also, somebody who awakens with a dry mouth, that's telling you that they're taking these breaths, and they're with open mouth, and that's usually also because of the snoring component, drying them out as well. They have a morning headache because of the difficulty they've had sleeping. They also suffer from insomnia. and I shouldn't say or, and they could also have sleepiness in the daytime. They have difficulty paying attention while awake because of the sleepiness related to the fact that they haven't slept at night. So the insomnia causes the insomnia at night causes hypersomnia during the day. And obviously your focus is going to be different. And if you haven't had enough sleep, obviously you're going to be irritable. General treatment for sleep apnea is going to be a CPAP mask or a BiPAP mask. There's also surgery that can be done to widen the approach to the nares that can then also, be of benefit in terms of that whole ventilatory status. But usually the treatment is going to be a CPAP mask. And the CPAP provides, as we talked about yesterday, we met, that it's continuous positive airway pressure. So it keeps the airway open so that you can adequately ventilate. Another reason for upper respiratory, obstruction related to trauma would be, or general obstruction, physiologic obstruction, is epistaxis, and that's a nosebleed. So if somebody, suffers trauma and has a nosebleed, but also sometimes when people are hypertensive, extremely hypertensive, one way the body actually protects itself is that those vessels in the nose rupture and basically, in essence, allow for that pressure to be dissipated. It's obviously a better place to have some kind of rupture than to have it in the brain. So sometimes, not rare, but occasionally what you'll see is epistaxis related to hypertension. Other reasons why you have a obstruction or upper airway issues is nasal obstruction, and that could be from a deviated septum, polyps, also a fracture of the nose could cause a problem with upper airway. And then, in terms of treatment, you want to control the bleeding if there's epistaxis, and you want to make sure that there's no laryngeal obstruction. So, if necessary, depending upon the cause, you could give epi to decrease swelling and open up the airway. Or if it's truly obstructed, you may need to see a tracheostomy performed or tracheotomy performed. Now, sometimes when there's like an extreme upper airway occlusion, you may see sometimes you hear people call it colloquial wise, a slash trach. That's not actually a slash trach. That's actually a cricoid thyroidotomy. And that's if you feel your throat and you feel the two pieces of cartilage that even, they're more pronounced generally in males than females, but females can feel it. It's those two pieces of cartilage that kind of protrude. They do a slash trach between those two and stick a tube. The reason that a tracheostomy tube is not placed, they don't use that approach, is that if you put your fingers there and you talk and you swallow, you'll see how mobile it is. Whereas the trachea down further is much more stable in terms of positioning, so that you don't have to worry about movement, which movement can always lead to dislodgement, right? So, excuse me. So basically, in regards to, treatment of an upper airway obstruction, you want to make sure that if there is swelling, you're decreasing that swelling, all right? And subsequently opening up the airway with epinephrine. Now, epinephrine, we talked a bit yesterday about the nervous system, right? We talked about the three parts, and the part that we were focusing on with the respiratory system is the autonomic nervous system. this is sympathetic and parasympathetic. The sympathetic system is what we're really focused on, and epi is both alpha and beta responsive in terms of adrenergic receptors. So it causes vasoconstriction, so there's no swelling, and it also causes the airway to open up, or bronchodilation. Problem, or I shouldn't say the problem, but the side effect of epi is that it also causes tachycardia. So you have to, monitor the patient's heart rate whenever you give epi. I spoke about epistaxis, and that's hemorrhage from the nose, and I spoke about the idea of one of the big risk factors could be hypertension, but it could also be as a result of a chronic infection accordingly. What you're going to do is you're going to pinch the nose for about 5 to 10 seconds. Now, phenylephrine is neosynephrine, all right? And when you're looking at drugs that cause vasoconstriction, there's 2 types of drugs that you'll see given IV when somebody's blood pressure drops. But in terms of just looking at the concept of vasoconstriction, vasopressors is another term in looking at vasoconstriction, all right? One way is medications that attack the alpha receptors. So the alpha receptors, the major drug that, and you may have talked about this in peds, the major continuous IV medication that acts on the alpha is Levophed or norepinephrine, okay? Phenylephrine, which is neosynephrine, is not an alpha drug. It's a drug that is basically looking to stop the action of histamine. And as you might remember from when you had A&P, histamine is your body's response to inflammation. So what does it do? It tries to stop whatever you might be inhaling that's no good. So it causes bronchoconstriction, and it also works to pull together, those components in the blood that would then attack whatever the organism is that's going to that localized region. So it causes vasodilation. So what phenylephrine does is that, in a sense, it works as an it works against histamine. So it's antihistamine in a sense, but it does, its major issue here is that it causes vasoconstriction. So that's why when somebody has hypertension, you want to look on the bottle to make sure, like if it's an over-the-counter drug, like a lot of these cough serums, that they don't have phenylephrine in them. And phenylephrine causes that, like I said before, it causes vasoconstriction. You also might see, if the bleeding doesn't stop like right away, you might see that they're cauterized with silver nitrate or electrocautery. And that's just, they basically, scar off the blood vessel. And then they could also pack it with a balloon, and either gauze packing, or they could use a balloon inflated catheter to cause compression. And then you may see antibiotic therapy if it looks like some type of severe infection caused it. So what this diagram shows you is that how they would do gauze, or how they would do balloon. Okay, so this would be the in terms of looking at the gauze, and then you're looking at the balloon. So you want to make sure that there's airway. I mean, without an airway, you don't have a patient. I know that how we treat, how we talk to people now in terms of CPR is we say, you can do, if you can't do, if you see somebody, you just do compressions, because people are even before COVID-19, people were very hesitant in terms of, doing full CPR on individuals, even with the protective gear. So, there is benefit to doing compression only CPR. But the reality is that has, that's not going to take the patient, the victim, or whatever you want to call the individual, to at least a stable state, so that ultimately, if you don't have an airway, you don't have a patient. So, you need to maintain that accordingly. So in terms of looking at upper airway, you're going to look at vital signs. You're going to look at monitoring, if you can, if the person's in the hospital setting. You're going to look to pulse oximetry. Anytime somebody's, becoming hypoxic, or they feel their airway is being obstructed, they're going to be anxious. There's no way you can get around that. And the only real treatment for the anxiety is to open up the airway. So there you go. But sometimes there may be, the patient may get some sedation in order to facilitate, better management of the airway on the part of the provider. So in regards to patient teaching, you want to avoid nasal trauma, taking, causes as to what might cause damage to the nasal region. So, like it says there's nose picking, but the idea of making sure that you're careful with that. And then forceful blowing, as well as looking at sometimes spicy foods, because even though you may be taking them in, the aroma, or the dissipation of the spice in the food can cause an irritation to the nasopharyngeal region. Obviously tobacco, and then exercise, because it also increases your blood pressure. You want to make sure there's adequate perfusion, because dryness can also cause a nosebleed. And if pinching the nose doesn't stop within a relatively short period of time, like 15 minutes, you need to seek medical attention. Now, in terms of looking at another thing that can cause, or another situation healthcare-wise that can cause problems, is obviously cancer of the larynx. And you're looking at a population that's generally older, and it's more common in men than it is, much more common in men than it is women. And the major risk factor in terms of laryngeal cancer is smoking. Okay. Early signs of laryngeal cancer is hoarseness, or persistent cough, a sore throat, or pain, burning in the throat, a raspy voice, a lower pitch, and then the obvious would be a lump in the neck. A later sign would be dysphagia, dyspnea, nasal obstruction, persistent hoarseness, an ulceration in that region, foul breath because of the breakdown of tissue. And obviously, when the problem with cancer in general is that it increases your metabolic rate dramatically. Cancer cells reproduce, or have a mitotic response at least 2 to 3 times greater than a normal cell, and they require a tremendous amount of energy. So that somebody with cancer, if they eat the same amount of food they always ate, they're still going to lose weight, because those cancer cells are going to eat up all of that nutritional status that the person is taking in. So that not just laryngeal cancer, but cancer in general, you're going to have a generalized state of debilitation. So, which is the following statement is true or false? An early sign of cancer of the larynx includes change in speech. The voice may sound harsh, raspy, or in a lower pitch, and obviously that's true. Now, medical diagnoses with regards to laryngeal cancers, you're looking at your history and physical. laryngoscopy, you're looking at it, so it's not even a question of, an x-ray or interpretation. With when you're looking with a laryngoscope, you're seeing it, and there's no, you're visualizing tissue. So there you go. And then they'll, with cancer in general, you have to do a biopsy to recognize the cell, okay, and to define the cell. You also may see a barium swallow test, because the barium will outline the esophagus, and then you could see against it any masses that might be there. And then, you could have an endoscope in regards to looking at, further visualization, and as well as your CT scan, your MRI, and your PET scan. Your PET scan tells you hot spots that you see a hypermetabolic rate, and that's generally what's looked to in terms of assessing that might be a cancer cell there. And then in terms of looking at the grade, the tumor grade, and I put that in here as well. Your TNM, your T describes the size and location of the tumor, N, are there node involvement, and M, as in Mary, is metastasis, which says, has it gone to other parts of the body? When you're identifying the cell, when you look at, where you might see other tumors, what you're looking at is, excuse me, is that the same cell? Because sometimes, occasionally, there may be two primary sites. So you may have one site, one cell growing in one part of the body, and another cell growing in another part of the body. So the idea of metastasis is you're looking at cell identification. In regards to medical treatment, with regards to laryngeal cancer, you're looking at radiation therapy, you're looking at a chordectomy, so they're going in, taking out, part of the larynx, in terms of the vocal cords, and you could do endoscopic laser excision. So instead of, actually going in with a scalpel, they use laser, and then more extreme would be a partial laryngectomy. In stages 3 and 4, you're looking at radiation therapy, chemotherapy, combination of both, and a total laryngectomy. So what this shows you is a picture of what happens with regards to a laryngectomy. So you're looking at where normally you would see your airflow happening. Now it's cut off to here. So the other thing is that remember that when you cut off the upper airway, you have to worry about what the upper airway does. So you're looking at gross filtering, humidification, and warming of air. So you have to think about how you're going to provide that accordingly. So hydration becomes important. You're also looking at a protection of that stoma. Nursing process, your assessment. Once again, you're going to look at your health history. So, what did the patient see that brought them to the hospital or to the primary care provider? You're looking at your physical as well as psychosocial and spiritual assessment. You're looking at nutrition. And like I said, one of the big things that you have to worry about is cancer cells eat up nutritional support. Cancer cells eat up nutritional support. Now, in regards to, trying to communicate with the patient, you want to make sure that literacy, hearing, as well as vision is adequately accommodated for, because speaking is maybe not going to be an option. There are devices, one device that kind of looks like a microphone that you place up against that laryngeal region, and it can give voice to some vibratory components that the individual might be trying to speak with. And then obviously you're looking at coping as well as support system for the patient and family. Because the other thing that's actually not on here is that when somebody's going through laryngectomy, there's an alteration in body image. And there's certain things that plastics can do to recreate, normal facial structures. But, it's never going to be exactly the same as before. And also, as an aside, remember there's a difference between cosmetic surgery and plastic surgery. Cosmetic surgery is that you have, generally speaking, normal structures, and you just want to alter your appearance. All right. There's nothing that physiologically may be that's wrong with you. Plastics is when there's something that is problematic, and you need to fix it. And that's what plastic surgery does. It fixes structures in order to facilitate more of a normal architecture of in this case would be the face and throat accordingly.
Professor.
Yep. Professor. Go ahead.
Just out of curiosity, patients with a laryngectomy, will they still be able to smell in a way? Since
No, because then they might smell a teeny bit, but the bottom line is that there's much less. It's a good point. There's much less air exchange, or air going through the nasal pharyngeal passageway. And I said this before, I think, that your five senses help you navigate your environment safely. So we always think about hearing, we think about sight. But, if you lose the ability of smell, you're not going to be able to smell smoke. And now and it's important, obviously, to always have smoke detectors in your home, but you may have to consider more smoke detectors accordingly to help that individual navigate their environment safely. That's a good point. In terms of diagnoses, knowledge deficit about surgical procedures, so you're going to have to explain it to them. And, the anxiety, you hear cancer, you think death. A lot of people in my generation or the generation before me, don't see that. But, a lot of the cancers are now very curable. So that, we need to, make sure that the individual is aware of, the cancer and what we have available for them accordingly. Ineffective airway clearance, so make sure that they know how to manage their upper airway accordingly. The idea of communication, that communication board. And as I mentioned about body image, so it's an altered body image, alteration in body image. And a lot when, you're looking at patients in general, when you're looking at trauma in particular, or, some type of surgical intervention, that's always something to consider. Body image and how the patient is perceiving themselves. And then the idea of self-care deficit, for them to make sure that they care for themselves appropriately. Now, in terms of post-operative nursing care for somebody with a laryngectomy, you obviously want to reduce anxiety, make sure that there's a good patent airway, that there's, control of secretions, that they have that alternative means of communication. When I think of this man, I'm just thinking of this man I took care of, who had a laryngectomy, and he was just very despondent. And we gave him the clipboard, and I gave him, a pen, and I said, just write down what you want. And that's like, not that this was like major, whatever, but he, as soon as he got that clipboard, and then he was able to write what he wanted and to use the communication board we also gave him, he had a different approach. I mean, it was like he saw himself in control, as opposed to, us bossing him around in another way, so, and once his focus of control changed, he had a better attitude in terms of his healthcare delivery. And, and he felt that, not that he didn't listen to us and didn't let us take care of him, but once he had that focus of control and could make his needs known, he was much more receptive and much more of a participant in terms of his own care. So that becomes like vitally important, not just with this, but in general. You obviously want to promote nutrition and hydration. Sometimes these individuals may need a gastrostomy too, long-term, alternative means of enteral feeding. So they may need a gastrostomy too, because they can't compensate for a good gag. And obviously hydration. And then you want to promote a positive body image, self-esteem, and once again, good self-care. Potential complications, obviously respiratory distress. Anytime you have surgery, all right, before you've actually got good scar tissue laid down, there's always the chance of hemorrhage and always the chance of infection. So, and subsequent to that is good wound care. You always have to worry about aspiration with these individuals. And then you don't want, you got to monitor closely tracheal stomal stenosis. And what that means is a narrowing of the stoma as that healing process and scarring component comes together. All right. So now what we're going to move into is we're going to move into the lower airway. All right. Now the lower airway, I uploaded these slides to, and all I did was add that slide in to show that there was a difference. There was a definitive separation between upper airway and lower airway. Okay. So in terms of, excuse me, lower airway, the big thing we got to worry about is pneumonia. Now, once again, this is easy to read. I mean, you can see here, everybody sees that arrow. So this is obviously a clear lung. So that's your left lung, and here's your right lung. And here you see well, it's actually circled for you. You see the density in terms of the pneumonia. So what you're seeing here is you're seeing buildup of secretions in the alveoli. So that you're looking at acute inflammation of lung parenchyma caused by microbial organism. And whenever you see the word parenchyma, that means tissue, organ tissue. So you could talk about lung parenchyma, you could talk about brain parenchyma, you could talk about pancreas parenchyma, so that when you're talking about parenchyma, you're talking about tissue. Bacteria is a huge source of an infection. And mycobacteria, you're looking at an offshoot of TB, fungus, as well as viruses. But usually viruses work in concert with bacteria. And as you see in the first bullet, somebody who has the flu, what you have to worry about is they don't develop pneumonia on top of it, because it's that pneumonia that further debilitates the individual and causes them to die. All right, so without the COVID-19, you're looking at you're looking at this. You're looking at, you know, what you would see with the general flu. But this is what you're seeing more specifically with the COVID-19. And with COVID-19, what they're talking about is the anti-malarial medication with an antibiotic. So they're looking at, you know, excuse me, azithromycin or Z-Pak with the, there's different categories of anti-malarial medications. And there's some postulations, the reason that you're not seeing the high numbers of COVID-19 in Africa is because of the fact that a lot of people are on the anti-malarials. But the major problem right now in this country is that sadly people are stockpiling the anti-malarials as well as the Z-Paks. But the anti-malarial medications are used for other diseases like lupus, so that some lupus patients are, you know, starting to see that they're having difficulties getting their medications. Now, you know, in terms of looking at pneumonia, obviously the discovery of sulfa drugs and penicillin has led to the decrease in morbidity and mortality rates. So when you're looking at when did sulfa drugs and penicillin come into play, you're looking at like probably the 1920s into the 30s. And that's when you started to see the development. One of the things that is being done now is that antibiotics used to be like, you know, if you had surgery, you got a week of antibiotics after the surgery. Well, if you use sterile technique, you shouldn't have to worry about, you know, getting an infection. So in regards to the utilization of antibiotics, you're seeing them very stringently used. You may see them only used for like 24 hours post-op at best. At most, I should say, not even at best, at most. So that why that's important is that because, you know, bacteria mutates. And if you have an antibiotic that kills it off, mutates so that it doesn't get killed off. So that's why you have multiple generations of different types of antibiotics. For example, cyclosporins. Right? So, you know, antibiotics are used much more stringently now than they have in the past. When I first started working, that's about 40 years ago, like I worked on a neurosurgical floor, and every neurosurgical patient came out on chloramphenicol and amoxicillin for 7 to 10 days. And those are really, really, really potent antibiotics. So you think those patients developed super infections, developed Klebsiella, whatever. Of course they did. So it took a while. But, you know, now healthcare realizes that, you know, we shouldn't be so generous, in quotes, with the utilization of antibiotics. In terms of pneumonia etiology, you know, your defense mechanism is become incompetent and overwhelmed, and you aspirate the bacteria. All right. So there you go. And in terms of you really need to be well nourished in order to be able to fight off the antigens that your body. Antigen means a foreign substance coming into your body. Okay, and antibodies are what neutralizes them, and they come in different forms, and the most common ones are bacteria. And gram-negative bacteria is a very potent antigen microbe that can come into your body and can lead to sepsis. And why you see an increase in terms of gram-negative infections that from leukemia is because of your diminished immune system. So you're looking at alcoholism, because people who are alcoholic, or they're not going to necessarily have a good diet. Excuse me, have a good diet accordingly. They're going to, they're not going to eat. Alcohol is empty calories, meaning that they're not calories that are useful as building blocks for tissue within the body. And then diabetes mellitus is bacteria likes glucose. And what's the problem with a diabetic is you have a higher circulation of glucose. So there you go. And also as far as physiology goes, your mucus and your mucociliary mechanism, so the mucous membranes as well as the cilia could also be impaired by pollution, by big one, cigarette smoking, other respiratory, the actual predicating upper respiratory tract infection, tracheal intubation because of the irritation of the upper airway, as well as aging. Okay, your immune system, starts to deteriorate once you hit that age bracket. What did I just do? Okay. So in terms of looking at ventilation problems, all right, the big problem ultimately with pneumonia, and we talked about this already, is this idea of the VQ. Ventilation perfusion ratio needs to be 1:1. So you're looking at ventilation is 5 liters, perfusion is 5 liters in the adult. Everything I talk about, unless I state otherwise, is in the adult. Is 5,000, so it's 1:1. So if something interferes with perfusion, if something interferes with ventilation, then, you're going to have a problem. So in this particular scenario with pneumonia, what's going to be damaged is going to be ventilation. So when you've got obstructed, airways, because of alveolus, because of mucus that's building up, and maybe some bronchospasm associated, especially if the person is has a history of asthma. Subsequent to that, you're looking at an alteration in the ventilatory component. So you're not going to have the same 5 liters per minute that a healthy person, or you, when you're healthy, would have. So then that would show a mismatch. So this is what I just said. So when you have a decrease in terms of ventilation, you're not going to have adequate supply of oxygen so that your arterial bed, your capillary bed, is not going to receive adequate amount of oxygen. So you're going to suffer from arterial hypoxemia, okay? So, which would then, in this case, lead to cellular hypoxia. So you're not going to, if you don't have enough oxygen put in the blood, then you're not going to have oxygen brought to the cell. Okay. I just mentioned this already. The idea of diffusion problems, the mucus and the inflammation is going to stop. It's going to interfere with the oxygen coming in and the CO2 going out. Now there's 2 types of, and it's terrible to talk about this, or I think it's the idea of what's reimbursable and what's not reimbursable. What's reimbursable is if somebody is in the hospital, and on admission is recognized as having pneumonia. Or if they're in the hospital, actually they've extended it. It's more than 24 hours. In general, it's 24 to 48 hours. But if you diagnose somebody's pneumonia in less than 48 hours after admission, generally it's considered community-acquired pneumonia, which means that it's reimbursable. Okay, and there you go. So it's a lower respiratory, you know, like I said, it's lower respiratory infection of the lung. A lot of people in the United States are diagnosed with it, and it has its highest incidence in the midwinter. And basically, the reason that you start to see the, you know, the flu dissipate in the summer and all is because of the ultraviolet light of the sun. It kills off the bacteria, and it kills off, you know, the viruses as well. So that's why, you know, your flu season starts like when winter, you know, comes, begins, and then you start to see it dissipate as you get closer to summer because of the ultraviolet light that the sun provides in the environment. And then smoking just is no good for anything, but smoking, because of the tar, interferes with your airway. There you go. So, the most common organisms that you see, Streptococcus, and that's, in greater than 60 with no comorbidity, less than 60 with no comorbidity, and then greater than 60, with comorbidity. Let me make sure I said that right. Wait a minute. Yeah, right. Yeah. And then there's other, Haemophilus influenza. That's, in regards to looking at the flu, but it captures also the pneumonia component. Legionella. The reason they call it Legionella was because of when it was first discovered. Now it's many years ago. There was a bunch of American Legion individuals who developed Legionella, who developed this pneumonia, and they named it Legionella because they were all these American Legion people, and it had to do with the ventilation system. There's also in the South Bronx, there was an incident of pneumonia in the same vein because of the water towers. So apparently, that was something I was kind of involved with, but apparently, not kind of, I was involved with it, that apparently there was like no inspection of the water towers. So you had these water towers that were servicing the community, and nobody was making sure that they were okay. Well, that's changed now, but it only changed a couple of years ago, so it's a little bit weird to me. But anyway, so, and then mycoplasma, chlamydia, as well as Pseudomonas. You can, Pseudomonas, when you come in contact with Pseudomonas, you can smell it a mile away. If you've ever seen, well, it's not a mile away, but if anybody's like had any kind of Pseudomonas infection, I've seen it with surgical wounds or with trauma wounds or whatever, but that has a pungent odor to it that you never forget. Now, in terms of community-acquired pneumonia, you're looking at the symptoms is fever, chills, productive cough that's purulent. It could be blood tinged, and pleuritic chest pain. That means that, as you're coughing, it hurts. And also in terms of clinical manifestation, there's dullness to percussion because of the consolidation. You have tactile fremitus because of, once again, the consolidation. The idea of echophony, as well as whispered pectoriliquy, once again, because of the consolidated tissue. And you'll hear crackles because of, and sometimes if the mucus is a little thicker, it may go to rales, not rales, rhonchi, but you'll hear crackles or rales because of the fluidity of the secretions.
Professor, would they have increase tactile feminist?
Increased. Does it say decreased on? Because of the consolidation, you'll be able to tap it because it's more solid in nature. I'll put something on Blackboard that goes through, those three things: tactile feminist, cacophony, and whispered pictoriloquy. I'll put something up on Blackboard with that. Okay. But just always remember that, when you've got something that's thicker than what you normally have as tissue, it's gonna have a harder sound to it. Okay, what did I do this? Yeah. Other clinical manifestations, it could have a, community acquired. Atypical manifestations would be a gradual onset, a dry cough. Other extra pulmonary manifestation, the person may become confused and stuporous because of the decreased oxygenation, especially in the in the older population, and Staph aureus may present only with dyspnea and fever while lung tissue is being necrotized. In regard to treatment at home, there's different research teams that look to what needs to be done, and you need to get antibiotics in as quickly as possible. There's every year there's a look to what antibiotics are appropriate for what types of infections related to what organisms. And I'll find that one. I'll show you that, because it changes every year. It used to be a little tiny yellow book with really fine print for really young eyes, but it's now online. It's now an app, but it basically, and it also goes by region. So what is common, a lot when we're talking about nationally and all of this stuff, you also have to look to region. So like what is endemic to the Northeast corridor may not be endemic to the Southwest corridor. Now, this whole thing with COVID-19, it's all over the country. But and nowadays with travel, a lot of that as a concept has kind of changed, but there still are some things that are more endemic to other areas. So that's something else I'll put online for you to see. I mean, that's not for you to, it's a prescriber's guide as to what, and that booklet becomes helpful, like if you're an NP, if you're going to, look from a nursing framework, you're an NP, you would use this guide in order to help you figure out what antibiotics to order. And this organization, AHRQ, the federal government under the current administration has taken a lot of money away, which I don't think is particularly very good. And in terms of community acquired pneumonia, you're looking at, different types of antibiotics that can be used. You're all probably familiar with the Z-Pak, Zithromax, clarithromycin, Biaxin, erythromycin. Some of these, more so than others, can cause gastric upset. And the other thing is that you want to make sure that you don't lose the bacterial flora in your GI tract. So, yogurt with those components in them that will help facilitate bacterial growth should also be given, generally speaking, with these antibiotics. So that general category of those antibiotics are macrolide, and then doxycycline is another medication group that you might consider. Okay. So that if you just that's right. A previously healthy adult, these are what you're going to use. For people who have comorbidities, you may see other medications used that are a little bit more, I don't want to say potent, but from an outpatient standpoint, maybe more apropos. So fluoroquinolone and beta-lactam are example, are other antibiotics to be utilized. And I'll just, this is more related to your primary care provider with regards to taking into consideration administration. Inpatient, you're going to look at, the fluoroquinolone, so that, you'll see like levofloxacin. I've seen that used a lot more. Also, the beta-lactam in terms of ampicillin, and also cefotaxime. And then you have to also consider what are people's allergies when you're given antibiotics, but when you're given any medication in general, you got to ask, nowadays we're much more appropriate in terms of assessing for allergies. So we ask, do you have any food allergies? The big one being peanuts, and and then you ask for medication allergies, and then in terms of, did you have a transfusion reaction? In terms of blood, because there's certain antigens that may be on blood, even if, let's say, you have, even if everything was done correctly, there may be something that is an extreme antigen antibody reaction with blood that isn't normally tested for, that you're going to look to. So, assessing for allergies, and especially, looking at penicillin in particular. So, in terms of looking at people that are not allergic to penicillin, you're going to obviously consider those medications, the beta-lactam, like ampicillin. You can figure that one out, that it's related to penicillin, and accordingly. But if somebody is allergic to penicillin, you're going to go to fluoroquinolone and azithromycin. Sorry. Just a little thought on food allergies. Sometimes food allergies may cross over to certain medications that that a patient might get. So there was some discussion about albuterol and peanuts, and there being a very minor or minimal link between the two, and that some people were not necessarily responding to albuterol as well as they should, and there was some studies suggesting a link between the two. It hasn't been confirmed, but that looking at allergies more grossly, or more across the spectrum, and seeing where they might be. Also, like when we talk about endocrine, it used to be like they took insulin from beef and pork, but now you have synthetic insulin. So for religious reasons, but also in relationship to allergies, there have been problems with insulin in the past, but that's just something to consider. In terms of complications with regards to community-acquired pneumonia, pleurisy related to pleural effusion. It gets absorbed because if you're recovering, you may need a thoracentesis. Atelectasis can result because you've got mucus in those alveoli, so they're not opening up. You could develop bacteremia, which is basically sepsis, and a lung abscess. Sometimes, I remember this one patient I had. She was an IV drug abuser, and she had used up all her access in her arms and other places, and where she ended up accessing her drugs was her heroin was in her subclavian vein, and she subsequently caused herself to have a pneumothorax as well as an infection. So she actually presented with a pneumonia that ended up becoming a lung abscess, an empyema, and then that empyema created a fistula that went into a pleural space. So she came to the hospital, obviously, in that late stage. So so there you go. So the idea of a lung abscess is usually a later symptom, or not even a symptom, a later sequelae to the pneumonia. And generally speaking, because the person didn't come to the hospital in a timely fashion. She actually lived for about 6 months after her admission, and she was always on a ventilator. And what they ended up doing was they did a bilateral rib resections, and you saw her lungs had been sclerosed by this infection, and we actually packed them with a solution called Dakins, which is basically bleach, and it really did keep her going, and we cleaned out that area. But she had other body systems that failed, so she ultimately died. But we at least were able to support her and get her to a point where maybe she would have had some type of recovery. But it sadly just didn't happen. Anyway, so so there you go. In terms of I told you about other complications. She had an empyema. Now it could spread the pneumonia if it's severe enough and involves the pleural membranes, can spread to the pericardium, and you develop a pericarditis. It's also you could also have meningitis accordingly, as well as endocarditis from the pericarditis. Remember, the pericarditis is the pericardium is what surrounds the heart, and the endocarditis is obviously heart tissue. Now, hospital acquired is what you do not get reimbursed for, and that's recognition of pneumonia about 48 hours after admission or longer. And the most common nosocomial infection or hospital-acquired infection is actually a urinary tract infection. About 40%, of all hospital-acquired infections are related to UTIs. Okay, but pneumonias are the second most common hospital-acquired or nosocomial infection, and that's related to, a debilitated state. It's related to immunosuppressive therapy, and the big cause of immunosuppressive therapy, the big an example of immunosuppressive therapy is steroids. All right. So, anybody who takes steroids over an extended period of time is at risk for developing infection, because one of the things with steroids is that they're anti-inflammatory. So your glucocorticosteroids decrease the whole process of white blood cell production. So somebody with a whopping pneumonia or a whopping UTI, your normal white cell count is 4,000 to 11,000. So like somebody who has a whopping UTI, you would expect them to have a white cell count of 20,000. It's not uncommon to see a white cell count much lower than that, 12, 10, whatever. So steroids are a big culprit in terms of seeing patients more prone to infection. General being in a debilitative state only makes sense and generally speaking, these are people who are not well nourished. I mean, nutrition is of the essence. When you look at the focus of nutrition in my lifetime in healthcare, in the beginning of my practice, you saw surgeons were very aware of, you got to feed somebody. This may sound silly, but it's not. You got to feed somebody in order for tissue to heal, because they had a wound that they created. So they created that wound, so now it's got to get fixed. So the only way you're going to get fixed is if you have the appropriate nutrients in order to have tissue building. Whereas medical doctors, this wasn't as noticeable to them. They had chronic illness and they were treating numbers. They were treating, the physiologic framework that wasn't as apparent to them as to surgeons with regards to tissue building. So that got fixed more like 30 years ago, and everybody's on the same page now and doing what needs to be done. Because if you don't have a positive nitrogen balance, if you're not adequately building the nutritional status of an individual up, they're not going to be able to fight infection. So it's an old concept. It's a very basic concept, but you need to do that. And then the idea of endotracheal intubation, it's a medical device, and it's gone past your normal body protection. So hello, you got to on a daily basis, does this person still need to be intubated? Treatment is obviously going to be based on risk factors, severity of illness, and whether, in terms of, exactly what the person might have been exposed to due to hospitalization. Aspiration pneumonia relates to something being sent into the lower airway. That's why if somebody's had a stroke, or if somebody has an endotracheal tube, or somebody has a tracheostomy tube. An endotracheal tube, you will never, ever, ever feed the patient, because you've taken away their gag reflex. All right, you've separated out, the tissue, the epiglottis. You've pushed it aside so that it's not separated it. You've pushed it aside, and it's not going to be able to provide the protection to the lower airway that you normally would have with not having the ET tube there. So subsequently, in terms of a tracheostomy tube, or somebody having a stroke, or somebody who's been intubated a long time, a couple of days, a week, you want to extubate. They're extubated now, but you want to make sure that their gag reflex wasn't damaged. So a swallow test must be done, and the swallow test is done by the speech therapist. Okay. Subsequent to that, if somebody does aspirate, you want to, take note of Actually, I'm still on this slide. The idea of tube feedings. That's why you're checking residuals. That's why whenever you put somebody's head down, that you make sure you turn off the tube feedings if they're continuous, because you don't want to go, for the person to aspirate. In terms of the different types of aspiration pneumonia, it could be mechanical. It could be chemical injury. You could have aspirated some GI content, and GI content meaning, the acid that's in your stomach, and bacterial infection. Opportunistic infections. These are opportunistic pneumonias. These are pneumonias that you see in immunosuppressed people. You're not going to see these pneumonias in in healthy people. All right. And these pneumonias bring back to me the AIDS epidemic, because that's what these people died from. They died from, if somebody had pneumocystis carinii pneumonia, PCP, they died. They died because, specifically if they got intubated, because of the fact that it totally destroyed their interstitial tissue, and they basically lost lung function. Your cytomegalovirus was to a lesser extent, and then different fungi. But the at-risk patients, if you look what's here, is in essence every single, the one that says immune deficiencies, but the other three, the reason they're at risk is because they're immunosuppressed. So severe protein calorie malnutrition, you don't have the building blocks for antibodies. So, you're immunosuppressed. Your immune system is knocked out. You have chemotherapy and radiation. Once again, immune system is knocked out. And then transplant, your immune system is suppressed so that you don't reject the organ. So once again, that's why these are. So when you think about opportunistic infections, and in this case specifically pneumonia, you're looking at people who don't have a functioning immune system. All right. And therefore, these opportunistic infections that all of us, are exposed to on some level, and it's like nothing. All right. So therefore, we're not affected by them. All right. But these individuals are. The opportunistic infections, you're looking at fever, tachypnea, tachycardia, and you're looking at fever, tachypnea, because once again, if you have an interstitial, if your tissue is being damaged, then that diffusion pathway is not going to work. So if the diffusion pathway doesn't work, then oxygen isn't getting into the vascular bed. So what's your body going to do? It's going to try to bring in more. So how is it going to bring in more? It's going to make you breathe faster. And it's also going to make your heart rate go up so it can send it around faster. You're also going to have dyspnea, non-productive cough, because with these opportunistic infections, you don't have mucus. And then, like I just said, you're going to have hypoxemia. In terms of diagnostic tests, you're going to look for history. Are they immunosuppressed? What their physical exam is. Their chest x-ray. Their chest, let me see. No, I don't have it here. Their chest x-ray is going to look whited out. It's going to look it's going to have opacities to it. And, it's not going to be like we saw in previous. Let me go back up to that one slide. Sorry, I'm just going to go quickly so you see the I thought I put one there. Anyway, so you see how clear this is. Now you see how there's density here. Well, that density is bilateral and throughout the lung fields. So this kind of appearance on chest X-ray is throughout when you're looking at those opportunistic infections, because they're actually attacking tissue. They're actually attacking tissue. Okay. And then you're going to gram stain sputum, which is done in the lab. And the idea of, rinsing the mouth, you want to get a good sputum specimen if the person's not intubated. And then you're going to look at blood gases. And, the blood gas on this individual in pulse oximetry is going to show poor oxygenation. And then you normally are going to look at CBC, differential, and chemistries, but you're looking at, on the CBC, you're looking at the white cell count and the differentials in terms of the different white cells, as well as blood cultures. So the therapy is going to be antibiotic therapy, O2 therapy for the hypoxemia. You'll give analgesias, pain, and antipyretics for the temperature. You're going to increase fluid intake and make sure that calorie count, calorie intake, 1,500 calories is actually nothing. You really should have at least 3,000 calories if you can. I remember this one lady, she had an opportunity, it wasn't PCP, and she was the character. She was she had HIV, and it was in the days when they didn't have the antiretrovirals yet, and she had C. difficile, and she had horrible diarrhea. And I remember she was getting TPN and a total parenteral nutrition, and she was getting tube feedings, but the tube feedings weren't cause of the diarrhea. We were just, trying. She was getting something like 4,000 or 5,000 calories a day, and she only weighed like 80, 90 pounds. She was a small woman, and we were barely, keeping, her weight at a stable point. She did survive, and her name was Norma. I can tell you her first name. And I remember Norma stopped me in the F-Link, and she says, because she had other opportunistic infections, and she stopped me, and she says, I think I should donate my body to science. She goes, because I should be dead by now. And I remember saying to her, Norma, I said, you shouldn't be thinking about donating anything, and just, do what you got to do to keep yourself going. But I don't, I'm hoping she's still walking around somewhere, but, she didn't die at Bellevue. She was admitted numerous times for different opportunistic infections, but she somehow survived each and every one of them. So I'm just hoping she's somehow out there. But this calorie intake, I should change this slide, should be at least double your normal calorie intake. You also want to make sure that the person has pneumococcal vaccine, because you don't want them to get a superimposed pneumonia on top of this opportunistic one. And there you go. So in general, with regards to looking at pneumonia, you're looking at ineffective airway clearance, ineffective breathing, acute pain. You want to make sure that nutrition is adequate and you have good activity. Now, the next thing that we're going to talk about is TB, and then I'll give you a 5-minute break. With TB, it's generally a potentially fatal contagious disease that can affect multiple parts of the body, but it's mainly the concern lends itself to infection of the lungs. And you know, tuberculum means round nodule, and osis means condition, in terms of where they get the name from. The causative in humans is the Mycobacterium tuberculosis. In animals, it's Mycobacterium bovis. And as mentioned before, pulmonary TB can be primary or secondary disease, but it doesn't have to be just in the lungs. And as you can see, it can go pretty much anywhere within the body accordingly. Symptoms would be persistent cough, chest pain, that's the coughing with bloody sputum, shortness of breath. There could be urine discoloration, and fever with chills and fatigue. Generally speaking, people with TB do not have a good nutritional status. So here you're kind of looking, what you're looking at here is symptoms of TB, as well as looking at the different sites where TB can happen. So you can look at your primary pulmonary TB, but it has extrapulmonary tuberculosis, can basically be in any part of the body. And you know, in regards to TB in general, it comes from, you know, the aerosolization is droplet nuclei, and so it's droplet precautions, okay? And yeah, none of you, I feel, are old enough to remember this, but there used to be a sign in the subway that said no littering, no smoking, and it also said no spitting. And the reason that it said no spitting, and even for me, that sign was a leftover sign from a previous generation, but they were in the subway. That meant that was there to prevent the spread of TB. And then, you know, so you have the, excuse me, you know, the aerosol, the droplet, you inhale it, and then it goes to the lungs, and then you're immunosuppressed, and there you go. Now, primary TB is the infection that of somebody who's never had it before. Secondary is you've had it, and now you're reinfected, in other words. And actually, you know, when you're looking at this concept of quarantine, and even pretty current to today, but in my mother's generation, if somebody had TB or any of these other infectious diseases, they would actually take the individual and put them in a separate place. Like, I don't know how many of you are familiar with Triborough. It's off of Queens Hospital Center, the Triborough Hospital, or the building. That used to hold TB patients. And then any of you that had clinical at Bellevue, when you look down 26th Street and you see the old building and you see those terraces, that's where they used to put the TB patients to get fresh air accordingly. And those were the old TB wards. So they would separate, and then they would quarantine the family for a while. And a public health representative, a nurse, would come by and check on the families accordingly, which is not really happening because of the sheer high numbers that that you're seeing. With the sheer high numbers that you're seeing, that's why you're not seeing people checking on people who are quarantined. Now, 20% of TB patients have different places, you know, where you might see the TB, and a huge population that has had TB in the past has been HIV positive individuals. And pleural TB means it goes from the lungs into the pleural space. So the lymph node TB, which is what's most commonly seen extrapyramidally in TB patient, in AIDS patients, so that the extra pulmonary TB that the AIDS patients see is in the lymph node. With pleural TB, it goes from the lungs to that pleural space. So it's not pulmonary in the purest sense of the word. TB can also go to your upper airway, it can go to your GU, it can go to your skeletal, it can go to your GI tract. As mentioned earlier, it can be meningitis, it can go to your pericardium, you can be miliary or disseminated TB, and it can be, in terms of your ophthalmic, your eyes, it can also play a infect or invade as well. Actually, if I'm not mistaken, I remember Eleanor Roosevelt died from miliary TB. The diagnosis of TB is bacteriologic testing, and you see where they actually do stains. You can do sputum, all right, sputum testing. The thing with sputum is that generally speaking, they don't look at one sputum and say, oh, you're negative, go ahead, you're done, get out of here. You need to do 3 separate sputums that are negative in a row. And that's not only because you want to make sure that but you're getting it from different, portions of the lung fields. So that's the deal with that. You want to see what your chest x-ray looks like. You want to, also look at, AFB, positive sputum, in regards to what the nucleic acid amplification that you're able to find. Acid fast bacillus, AFB is acid fast bacillus, which is the TB, microbe. And then you're looking at, once again, the idea of, it's on the next one, actual skin testing for TB, which I think most of you are familiar with. So what, in terms of skin testing is they put the the test substance underneath your skin, and they look for a reaction in 48 hours. What's most effective is it's a quantiferon in terms of the interferon gamma release assay. This one is the most efficient means. These type of tests are really the most efficient means of testing. Have you, been exposed to TB? And then, and if this comes back positive, either of them, you have to go for a chest x-ray. If you have TB, if your PPD is positive, then you have to go for a chest x-ray. The other things that can be looked at is different types of cell counts in terms of lymphocytes, and then to look at the different proteins that are available for you to, not available, the different proteins that may be seen in different body secretions or body fluids that you might see from ascites or pleural effusion or from your CSF. These are the drugs that are most commonly used for TB, all right? So INH, which is isoniazid, and rifampin. Rifampin can also be given IV. It's not just a PO medication. Secondary is ethambutol, pyrazinamide, which is PZA. You might see it, streptomycin, para-aminosalicylate acid, thiocyanazone. Streptomycin, if somebody's on streptomycin, and any of the mycins, not just streptomycin for TB, but you have to worry about hearing deficits. So people that may be placed on streptomycin need to be tested for hearing on a regular basis to make sure it's not compromising it. And then the tertiary drugs are, as you see listed, ethylamide, cycloserine, kanamycin, and capromycin. And that's it. All right, so we're going to take a little break, if that's okay, for 5 minutes, and then we'll finish up for today. Is that okay with everybody? Hello?
Yep, sounds good.
Okay.